Hi, this is Dr. Daniels, and welcome to Healing with Dr. Daniels. And today's show is the medical industrial complex creating a caste system? Yes, a caste system. But first, let's take our turpentine. And for those of you who want to know more about how to take turpentine, visit my website at vitalitycapsules.com. Enter your email address, and you'll get your free report on the wonders of turpentine. Definitely would not recommend doing this without reading the report. Probably a couple times, actually. All right, I have turpentine in my itty bitty bottle here. It's my little pipette, the one that I like. Capacity 2.5 cc's. We just have a teaspoon. Absolutely perfect. It's the dose I like to take. As you see from the report, you get to pick your own dose. All right, and we have sugar. Yay, white sugar. Benefits of white sugar. And we're just going to squirt this onto the white sugar. Yay. All of it, all of it, all of it. And some water. As Mary Poppins says, a spoonful of sugar helps the medicine go down. All right, that's turpentine down the hatch. Next is Shilajit. Usually I don't lick my lips after turpentine, but no, today everything's okay. Shilajit black tarry goo. I do not like the taste of this. I'm going to tell you right now. All right. So you just take this little stick here. It's a scientific spatula is what it's called. And you get a little clump of Shilajit. That's a little generous, but it will work. Take that, put it in the water. As you can see, it does not dissolve easily, so we're going to let it sit for a bit. Okay. Vitality capsules. I am thrilled to report we have located all the ingredients for Vitality capsules, regular and extra strength. Yay! Extra strength is in stock, but stocks are low. Regular, so you can still order extra strength at the website. For regular, we are not any longer taking pre-orders. We have a really large amount of back orders. And so we hope that when they are released, we will have enough for everyone. So we'll be sending out emails letting people know when the regular strength Vitality capsules are available for purchase. And obviously, since we have a limited amount and difficulty keeping them in stock, as you can see, we won't be having a sale this time around. That's the Vitality capsule story, but I want you to know we've really gone through a lot of expense and time, making sure the ingredients are high quality. We've rejected quite a few, and we're really excited to bring this new batch to you. I am absolutely thrilled. And we are actually, I say the royal we, but me included. So as soon as this batch is complete and ready for your purchase, we're going to immediately start sourcing the ingredients again for the next batch. The way that natural herbs work is that the place where you buy a particular herb from now might not be the best place 3 months from now. So the process, we have to go through the process each and every time. It's not the kind of thing where you can just pick your favorite source and stick with it, which is unfortunate. But whatever it takes, I am determined to be sure that Vitality capsules are of the highest quality and they provide you the cleansing that you need to experience a wonderful life. They are just amazing. That's the Vitality capsules. And that brings us to today's show. So I've talked to a lot of people, and there seems to be an incredible amount of misunderstanding. And so today, what I would like to do is, by way of comparison, paradigm, examples in plain English, explain exactly what is going on and how we are entering a caste system through medicine. Now, a caste system, let me just refresh your memory, is when a society governs itself by putting people in different social classes with different privileges, irrespective of their talents or abilities. And a person during their lifetime generally does not have the ability to exit that category or that class. Okay, so the first thing you have to do when you create a caste system is you have to create the appearance of legitimacy, especially in a culture like the United States where people are feel it's merit-based. So what you have to do is create the appearance that this is fair. This is fair. So the first thing you do is you create a test. And the test is, it has to be, by definition, because you want to create the authority to put people in whatever group you want to put them in based on political considerations. So the test has to randomly be positive in healthy people. And it has to be unrelated to any type of illness. This is very important. So, and the test also does not test for any organism. In other words, it has got to be an antibody test. And so we can see with COVID that that's what we have. The test is randomly positive in healthy people. What does it mean? 80% of the time when the test says you've been exposed to COVID, you have not been exposed to COVID. Again, this is according to the CDC's own research papers. So if the test is positive, then it's pretty much meaningless. The next is the test cannot possibly test for any organism. So this gives the flexibility of creating the rules for the caste system. So you don't have the interference of a live organism that might have its own patterns of behavior. For example, if you have a dog and you have the dog test, and you want to put chickens in that category, well, it's going to test for 4 legs and the chicken's only got 2 legs, so that kind of messes up your plans. Similarly, so the test cannot test for any organism. So an antibody test is what is needed. And we see this with HIV/AIDS, and we see this as well with COVID. Now the test has to have a positive predictive value of less than 50%. In other words, a healthy population that is tested will generate a massive number of positive results when there is no disease. And so this allows the manipulation by just deciding who to test. You can decide you're going to test dead bodies and you're going to test people who are sick, in which case you're also testing people who are more likely to die. And so when they die, you simply attribute the death to the positive test. And you say, see. And so you get a set of symptoms that are so vague that they include a large number of people. And this initially was what we had with AIDS. So the initial symptoms of AIDS was a fever and a rash. That's pretty general. At that time, back in the 80s, they did have a particular rash, which was a purplish color raised with irregular borders. If you check now, you'll see that if that definition has changed, it's broadened. Very interesting. Next, you limit testing to those who have symptoms, like I said, or, as in AIDS, to a particular group. So in AIDS, they wanted to label a particular group, for example, homosexuals. And now it's prisoners. So they test all people entering prison. If you're not in prison, then of course you can say, well, I don't think I'll get that test. So because the test is randomly positive, whatever group you decide to test will be positive. And you can then adjust the status of that group. say, oh, wow, you tested positive. You've got it, like cooties, for example. And so a set of symptoms that are vague have to include a large number of people. And you also limit the testing to certain social groups. For example, in the United States, healthcare workers are not being tested. And that lets you know that they are a high status. For example, my brother got a job solving a very important computer program for a very large corporation in the United States. They told him, you don't need any pre-employment tests, you don't need any vaccines, nothing. We just want you to get this done. So again, your status determines your testing. And the other thing that happens is there's a list of restrictive behaviors to be followed by everyone. Whether first of all, whether they're positive or negative. For example, with AIDS, which is a prototype, because the COVID example is just step by step, just like the AIDS. Restricted behaviors be followed by everyone, like a curfew, stay at home, wash your hands, wear a mask. And then you create exceptions for certain people in certain groups. For example, essential businesses. And what's essential and what's not, when you look at it, is actually pretty arbitrary. And so what this does then is the people who don't have to stay at home, who are allowed to work, have an economic advantage. They have resources, they're able to buy things, and they're not deprived in any way. And so this is what creates the caste. And then when there are not enough cases or people are not scared enough to obey the caste rules, you change the method of diagnosis to exclude the test. And then the diagnosis is made by impression. You look like you have it. I think you have it. Or accusation. You definitely have it. Or symptoms only. And so again, you've based the test on vague symptoms that broadly the whole population has. I don't think many people remember that the initial symptom for AIDS was flu-like symptoms. And what happens though when they change the criteria for the actual diagnosis from not just the test, but expanding it to symptoms, now you have a greater number of people who have it, and you can basically manufacture the appearance of a large number of people who are affected. And this is what we saw happen with Johns Hopkins. When Johns Hopkins changed the criteria for COVID from a positive COVID test to a cough or a sneeze, to the appearance that it's likely that COVID might be related to death. And this caused a spike in the deaths of like 100%. In one day, boom, the deaths from COVID doubled. And so that is the political manipulation that is used to control the population to get them to fit into their particular caste group. And so again, it creates the impression the disease is worse, and intimidates people to obey more or obey better in order for the disease to improve. And again, when the protests erupted to COVID, Johns Hopkins the next day showed up with the new criteria. And so now the people who don't want to stay in their caste system, who don't want to stay home, who don't want to deplete their savings, who don't want to spiral into poverty and hardship, are accused of endangering the country and endangering the health of others. And of course, again, these instructions for doctors to list COVID as a cause of death, even if there is no test performed. Now, this is then used to further restrict the behavior of healthy people under the pretense that the healthy ones must follow the restrictions in order to stay healthy or for the sick ones to be protected. And this permits control of the population, like protect the elderly by quarantining the young, for example. Place tighter restrictions on those. So this, of course, makes no sense at all. Why can't a young person be a bus driver and drive a bus because someone in a nursing home is having a bad day or has COVID? He's not even going to go to the nursing home. Nowhere near it. Why should a restaurant be closed because a person in a nursing home is not feeling well? So they draw these totally non-scientific, absolutely superstitious associations. Now, the next thing it helps is the idea of chameleons. And on March 23rd, national science people, National Institutes of Health said mimics and chameleons of COVID-19. So they then develop a list of things that could be COVID-19, and we should, reconsider the diagnosis. It's not what we thought it was. Oh no, it's COVID-19. It is COVID-19. So as recently as April 8th, we have, a popular doctor going on TV and saying, hey, heart damage is now an indicator of COVID-19. And so, again, this is an example to widen the number of affected or influenced individuals and to make it appear to be an issue. Now, the other thing about COVID, when you look at how deadly is it, you've got to make this thing appear pretty darn deadly in order to get people to abandon their incomes, abandon making a living, abandon their ability to feed their families, and even abandon their families themselves with social distancing. Children not being able to visit their grandparents, for example. And so here in Medscape, they really bring this home by saying almost 90%, we'll call it 9% because, our math is weak, let's keep it simple, of COVID-19 admissions involve comorbidities. What does that mean? Comorbidities. Underlying causes. So I was talking to a friend last night. We talked for a long time. We hadn't talked for 5 years. And she says, oh, yes, I understand that a lot of COVID deaths have underlying issues. And then we were talking, and she said, but what are they, if they're not dying of COVID, what are they dying of? And I was like, we obviously have a misunderstanding here. So it occurred to me that same misunderstanding is prevalent in the general public when they hear about COVID. And this is from the MMWR. And this is the mortality and morbidity weekly report put out by the CDC. It says the hospitalization rate for COVID-19 is 4.6 per 100,000. And 90% of hospitalized patients have some type of underlying condition, according to the Centers for Disease Control and Prevention. So the hospitalization rate is high if you for COVID-19, and 90% of those have a underlying condition. Now, hypertension, obesity, chronic lung disease, diabetes, and cardiovascular disease. These basically are other diseases that explain why they're in the hospital. Right. So they have a reason to be sick so their illness could be easily explained by other factors other than COVID-19. So, for example, 90% of people are going to have a condition like emphysema that could totally explain their illness, or diabetes that could totally explain their illness and their death, and cardiovascular disease that could totally explain their illness or death. But instead, again, this test is done that randomly labels people as positive, whether they've been exposed to the virus or not. And in the 90% of people who are COVID positive, what they're really saying is there's actually another plausible reason for their death. That COVID-19 is not the only reason why they would die. Another way to look at this is, imagine you're a doctor, person's been in the hospital, they drop dead, and you gotta fill out the death certificate. Well, did they die of the diabetes? Did they die of hypertensive heart disease? Or was it their emphysema that killed them? Oh, wait, they're COVID positive. It's COVID-19. So 3 years ago, that exact same patient, exact same situation, I can tell you they would have picked heart disease. Why would they pick heart disease? So as doctors, we are instructed when filling out a death certificate to fill, basically, I'm giving you the gist, to fill out the diagnosis that would yield the highest dollar reimbursement for the hospital. And at the moment, that is heart disease. So even if a person happens to have cancer, it's heart disease that got them. If they happen to have high blood pressure or something else. So this is how death certificates realistically are completed. There is no autopsy or investigation or official criteria for completing a death certificate. In general, if you're a doctor at a hospital and you're filling out the death certificate, you darn well better put down the highest paying diagnosis. And actually what happens as well, if the doctor misses it, they have a coding expert in the basement who changes all the diagnoses to make sure the diagnosis with the maximum payment for reimbursement appears at the top. And so Medscape inadvertently lets the cat out of the bag by saying that 90% of COVID-19 admissions involve comorbidities. In other words, they have another diagnosis that could easily be put down and that in the past would have more than explained their situation. And so this allows then the arbitrary overlay of a condition that can be used to terrify people into fitting into their allotted slot in the caste system. Now, once you get people in this frenzy, which apparently they seem to be, then what you can do is you increase the restrictions on the behavior of healthy people under the pretense, like I said, that the healthy ones must follow the restrictions in order to stay healthy or for the sick ones to be protected. And this permits to control the population. And here we have an example. It says, on Medscape, CMS, Center for Medicare Services, loosens telehealth clinician scope of practice rules for COVID-19 crisis. Can we get an English translation on that? Woo! So the Government Insurance Oversight Agency says that they will pay for physician or clinician patient encounters even if the clinician and the patient are in separate locations. When I was in medical school, that was considered like malpractice. If that patient doesn't show up and you don't lay on hands, that's it. Malpractice, fraud, can't bill. So now what they're doing is saying, okay, no. We're going to change the rules. So now that medical practitioners are home, they're saying, we don't want all the medical practitioners to sink into an economic lower class. So we will continue payments to them and loosen the rules for them. And that's what it says. They loosen the rules. Now, I'm telling you, you can't make this up. So to boost the capacity of frontline clinicians and make it easy to fight COVID-19, the Centers for Medicare and Medicaid Services on Thursday announced it is temporarily suspending rules to allow physicians to provide telehealth services across state lines. They're even allowing the doctor to use his medical license in one state in many states. And that's huge. That's actually violating, I won't say violating, but superseding, overruling state licensure rules. And physicians can now care for patients at rural hospitals across state lines by phone, radio, or online communications without having to be physically present. When I say physicians can do that now, that means they can get paid for it. They could always do it, they just weren't going to get paid. Remotely located physicians coordinating with nurse practitioners at rural hospitals will provide staffs at such facilities additional flexibility to meet the needs of their patients, the new release said. So now we have the nurse practitioners who are back to work, right? Because the telemedicine allows that, and the doctors who are back to work. So we have money flowing now to these two categories of individuals. Skilled nursing, at skilled nursing facilities, nurse practitioners will now be able to perform some medical exams that doctors normally conducted on Medicare patients, whether they are COVID-19 related or not. But wait, I thought we were trying to increase the capacity for COVID-19. So what's really going on now is they are telling the doctors, okay, you can work remotely and talk with the nurse practitioner who's implementing whatever therapies. And so obviously this is a transition from totally jettisoning the doctor. And this law applies to non-COVID-19 patients and cases as well. And so this is how you can see that what's being done here is we're creating a caste system. And it gets even better. So you're like, oh, Dr. Daniels, you're not, you're over-interpreting this. This is not, it's not the case. It can't be. I have to find this article for them. So miraculously, somehow, social workers are not allowed to work remotely. They are not allowed to get paid during the COVID epidemic. And so what this does is it takes the social workers and puts them lower on the economic totem pole and really puts them down and limits their economic opportunities. So what you do then is you artificially elevate the doctor, the nurse practitioner, and the nurses. That's one caste. And then you take another level, the social worker, and artificially lower that caste. So that person can't work from home, for example, and pay their bills. And so they even have a lawsuit now about that. So New York State hospitals require healthcare workers to report in person, even for phone and telehealth work. So here you are, you're a doctor, you're talking to the patient on the phone, and you have to talk to the patient on the phone or from the computer at the hospital? You can't do it from home? And so what this is doing then, like for this particular social worker, who's home caring for his sick son who had COVID-19, and his hospital told him he had to show up in person. And of course, social workers, all they do is make a bunch of phone calls to try and get services put together for a patient. Perfect job for working from home. But no, social workers, you guys, stay in your place. And so what they're saying is there's no good reason that social workers should be compelled to be physically at work during the pandemic. And so what's really going on here is the creation of a very firm caste system. There are people who have more economic freedom to work than others. So doctors versus social workers. versus airline stewardesses versus carpenters versus online shopping versus brick and mortar businesses. So these are all of the caste differences that are being made. And so we can see this whole caste system emerging and taking form under the guise of, well, we're going to open up gradually. We're going to open up just so. And so we now have a document from the World Health Organization. And it's not just the World Health Organization. I believe the CDC has their own document as well. CDC issues new return to work guidelines. Now, let's see if we can. Now, these are from April 9th. But we have more recent ones from the World Health Organization, April 15th. So let's use the World Health Organization information. So the World Health Organization sets 6 conditions for ending a coronavirus lockdown. And they give you a bunch of yakety yak, but let's just take a look at the 6 conditions. The first condition, disease transmission is under control. So, again, there is no disease transmission. We know this because we have a test that generates random positive numbers from people who have not even been in contact with the disease. So if you're using disease transmission, interpreting that as number of positive tests, then the disease transmission is only under control when the person in charge of testing and definitions says so. So the first thing the World Health Organization says is they need the go-ahead of whoever's running the epidemic to say the transmission is under control. All right, great. That is something none of us has any control over. I mean, I certainly don't. I mean, no one asked me, and they probably haven't asked you either. Next, the health system needs to be able to detect, test, and isolate and treat every case and trace every contact. Now, remember, there is no effective treatment for this condition. So since there's no effective treatment for it, why does the health system need to be able to treat every case? That's fraud. That is absolute fraud because there's no effective therapy. The next thing that they're requiring is they need to detect. That means everyone needs to be tested without their consent. They need to be able to detect. They need to have a way to detect and test everybody. Again, this is to help sort people into a caste system. And isolate and treat every case and every contact. And again, since the mode of defining a case used to be a positive test, now cases are defined by accusation. And so the health system needs to be able to monitor and label every single individual in the population. Now, this is a condition the World Health Organization has set for ending the coronavirus lockdown. It doesn't sound like it sounds like a new lockdown to me, but you decide for yourself what you think. Third thing is hotspot risks are minimized in vulnerable places such as nursing homes. I got news for you. A lot of people die in nursing homes, and the only way to reduce the risk of dying in a nursing home is not to go. The only way to reduce the risk of dying of COVID in a nursing home is to stop testing and stop labeling nursing home residents as having COVID. That's it, because they're going to die. There are certain conditions in the nursing home that create an environment very high in death. So hotspot risks are minimized in vulnerable places such as nursing home. Well, now we don't know how long the list of vulnerable places goes and what authority the World Health Organization feels needs to be had over all these places. For example, there are policemen patrolling parks, telling people, and beaches, telling people, oh, you can't be here. So are those hotspots? Next, schools, workplaces, and other essential places have established preventative measures. Again, so now the government has the right to interfere in essential places. What's an essential place? Is your home an essential place? And what's a preventative measure? Does the government get to give you a ticket or fine you or give you an extra tax if you don't wear a mask in your house? Communities, I'm not sure what that is. Communities, that must be groups of people, are fully educated. That means they believe and they have information. Engaged, that means they're doing things, and they're empowered to live under a new normal. So we're lifting quarantine, but only if we can get people to live under a new set of controls, which by any measure, again, is unnecessary, because this is all an exercise in without a virus, without a disease, without an illness. So the worldwide number of COVID-19 cases is quickly approaching the 2 million mark. Let's call it 2 million. 8 billion people on the planet? Really? You're telling me 2 people in 10,000? 2 people in 10,000 might have this? Doesn't sound like a problem to me. And it's had 3 months, and this is the best it can do. There are over 320 million people in the United States alone, and there's not even 2 million affected people in the United States. Oh, I'm sorry. These are ones who have died. But still, this is a very small number. 1 in 10,000. The death rate in the United States per year is 100 in 10,000. So, you have to wonder what's going on here. Now, according to the COVID dashboard created by Johns Hopkins University School of Engineering. Now, we know about Johns Hopkins. They've changed the definition to include more cases. And the number of cases continues to rise sharply in the U.S., again, where the definition has been changed, where disagreements over the potential restarting of economies recently prompted 10 states to band together in a regional coalition. And so, now, this is shocking to put this much authority in a system, medical system. We have COVID-19 physician gag orders. Those were put in place on March 25th. We have the discovery that the ventilator is killing many COVID-19 patients. In other words, we have an organization we're entrusting with our health that's actually killing more people than the virus. Rapidly changing personal protective equipment policies sow confusion. So we have the medical situation changing quickly. You can reuse your mask. You can't reuse your mask. You can reuse your mask if you wash it. You can wash it this way. You can't wash it that way. And so this is the way things go when you're dealing with a imaginary situation. So if it was a real situation, then you could just do a mask test because you have a real virus or a real infectious particle, and you'd have your answer. But when it's imaginary, you have all this rule making kind of on the fly. When COVID-19 first hit hospital administrators limited surgical mask use to providers treating patients with confirmed COVID. Then the policy became masks in rooms, but not hallways. Only when the governor declared everyone should wear face masks in public that the hospital allow masks to be worn in hallways too. Elsewhere, a neurosurgical unit at a hospital in Minnesota was converted to a COVID-19 floor mid-shift. The staff, who rarely wore masks, had to scramble for guidance on what to use and how to wear it. And so this is an industry that doesn't even know how to wear a mask or how to use a mask, and where citizens are supposed to ask for guidance from these people. Normal chest x-ray does not rule out COVID-19. Again, we have an imaginary situation, and they need to get healthy people to believe, oh, I've got it. So now a normal chest x-ray, which usually means you're healthy, like, oh, no, you can still have COVID. You can still have COVID. Believe. Even more importantly, it gets the doctors to believe and to overtreat and to administer a deadly drug. Now, we have this also from our history with AIDS. So you have these restrictions, and then you enforce the restrictions with a penalty or a fine. That would be police power. And then, in this case, if you violate curfew, then there's police power. Or you also enforce restrictions with the denial of privileges. Oh, you can't enter the store, you can't shop if you don't have a mask. And then you change the symptoms of the disease to be inclusive of already existing diseases that the population already fears. And as we can see, heart disease is now being added to a list of COVID symptoms. And finally, you have to introduce a lethal medicine that kills over time and change the definition of the disease to fit the side effects of the medication. In AIDS, this process is completed, and now lipoid dystrophy, a medication side effect, is now listed as a regular AIDS symptom, whereas when AIDS was first discovered, there was no lipoid dystrophy. So now what you're saying is a normal chest x-ray does not rule out COVID. You could still have it. And that's an issue. And how to sanitize N95 masks for reuse. Initially, and certainly in medical school, we were taught they could not be reused. And so now they're saying, well, you can have vaporized hydrogen peroxide or ultraviolet light. It eliminates the virus from the material and preserves the integrity of the mask, fit for up to 3 uses. And they're saying that they did test it, and they want to reassure clinicians it can be used 3 times. That's not very many uses for a clinician that's working. 3 uses could be expired in 1 shift. Then we have in pursuit of real coronavirus numbers. And what they're saying is there's one question everyone wants to answer: whether it will be safe to get back to some version of normal life. Opening the country back up safely to limit the economic devastation of the shutdown depends on aggressive testing and tracing. So they want everyone to submit to testing and being traced, which many say the U.S. public health system is not equipped to do. Should it be? Should it be equipped to trace and test using a test that is false 80% of the time when it says it's positive? Probably not. So on Friday, researchers posted a preprint declaring the number of people infected with SARS-CoV-2, which is COVID-19, in one California county is far, far higher than previously thought, making the presumed death rate much, much lower. Another recent article suggests millions of people across the United States had already contracted COVID-19 in March. Yeah. These findings come with an appealing implication. In the words of one article in The Economist, it's a very well-respected international paper, if millions of people were infected weeks ago without dying, the virus must be less deadly than official data suggest. And the answer, of course, is yes, it's not deadly at all because, well, it doesn't exist. And because the test, if the virus does exist, the test is not even testing for it. And so, therefore, correlating death with the testing is more of a magic trick, more of a chance association due to artfully maneuvering the test. Data from these studies supports the current push to end the lockdown that have strained the world's social and economic fabric, as one Wall Street Journal opinion columnist wrote. The multiple scientists, now scientists have a bias, right? Because if you say coronavirus exists and you believe the test and take it seriously, it creates a lot of work for the scientists. And so they're giving it, this is a very biased, unreliable interpretation. There's way too much financial pressure on the scientists. So they are saying, well, we're not going to believe that study. So in pursuit of real coronavirus numbers suggests, and I think the public should know, that there's not very much agreement on the actual numbers. And certainly all the predictions of death have not materialized. And here, this is April 17th. Talk about late in the day, April 17th. COVID-19, our ignorance is profound. That means the doctors don't know a lot about COVID-19. Unusual presentations of COVID-19. Again, so what's the public is what's not being sure of the public is nobody knows. And again, when you have a made-up story that's being put out by a central authority, of course, feet on the ground doing research, they're not going to be able to do research to confirm the fantasies and stories that are woven and spun by the central authority, especially if you don't know what the final caste system they're trying to create is going to look like. Here, although a cause and effect relationship is not known, people with the virus have presented with or developed heart disease, liver injury, ongoing stomach issues, skin manifestations, it's called a rash, neurologic damage, we'll think stroke, and other problems, especially among sicker people. I think the sicker people have developed sickness. So again, what they're saying now is they want to label all these symptoms as part of COVID-19. And pretty much that amounts to taking the present death and relabeling it as COVID-19. And the way that you know this is happening is you go to the CDC website where they're following COVID-19, and in the far right column they say what are the deaths this month compared to the same time last year. Now, the last time I did a show, I told you that none of those numbers were over 100. Well, now for 4 weeks the numbers are over 100. But wait, what about the fifth week? It's down to 53%. So again, what that suggests is the numbers are being the deaths. These are the total death columns. One thing you cannot fudge. How many dead bodies are there? It's like a trial of habeas corpus. If you're accused of a crime and they can't find a body, you can't be convicted of a murder when there's no body. You can't be convicted of theft when the money is still where it's supposed to be. So you have to have, so in this case, a dead body, right? So we're saying that the COVID virus is deadly, so where's the dead bodies? So we have 4 months where the death rate is higher than 100%. That means higher than what it was last year, this time. However, I can never seem to find that thing. Yep, there we go. There we go, there we go, there we go, there we go. Okay. So I'll just read the numbers to you. 96, 96, 96, 97, 96, 94, 94, all the way up until March 21st, the death rate for the whole year was less than it was last year. It wasn't until March 28th that the death rate for this period in 2020 was the same as it was for last year. So prior to the quarantine measures, there was no evidence of any threat whatever to the health of the public. these numbers change all the time. So on the 4th of April that week, it was 9% higher than this time last year. On the 11th, it was 3% higher. But wait, on the 18th, week ending 18th, it was 62%, which is lower than it was last year. So again, we don't have evidence of an epidemic here. What we do have is evidence that deaths are being rearranged. So you add it all up, cumulative deaths this year, 2020, remain less than they were last year. Because we have 1, 2, 3, 4, 5, 6, 7, 8, 9 weeks with deaths, total deaths, are at or below last year's level. 2 weeks where it was higher and only slightly so. So if there was an epidemic, it's already passed. And if it was there's no evidence. Again, there's no evidence of it. So there's no increased death this year compared to last year. And so, again, the doctors are saying, hey, our ignorance is profound, and they want to extend their ignorance by, we've just learned that every death should be considered a COVID death. And again, that's not helpful, right? Because you have a person who died. You would have called it heart disease a year ago. Now, same death, same circumstance, you're just renaming it. So there's not any increased risk anywhere. Okay. So they are discussing their lack of knowledge. And CDC issues, like I said, return to work guidelines. Let's go back to the rest of their guidelines. Oops. Oh, that was the last one. To have the community activated and forcing compliance on the part of the individual. And so what's going on here is absolutely no plan to return to normal. No plan to allow people to come and go freely from their homes and to work freely. There's no plan for that. And so we see this new Caste system emerging. We also see scarcities being created, limiting times, how much, and what foods people can buy. Now, you've got no control over this. The question is, what do you do? How do you handle this? The only way to handle this, or so as I would say, is, well, what's a serf to do? And the thing to do is you have to reduce your dependency on the system that is implementing the COVID situation. So totally reduce your government dependency, your grocery store dependency in every way you can. Get a tower to plant your own groceries in your living room. One tower can easily provide all the vegetables for a family of 2, maybe even a family of 4. Consider bartering your vegetables for the meat that someone else might be growing. Take a look at your electricity use. What I did, even in the 90s, was I unplugged all the light bulbs in my house so that no lights would go on. So we got up with the sun, we went to bed with the sun, and each kid had his own flashlight, and if he felt he had to go someplace in the house and it was dark, they could use his flashlight. And they just didn't. I had no problem getting up in the morning because they went to bed with the sun. So, and our electric bills, oddly enough, went way, 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 way down. What many people don't realize is the lights in the house are the gateway for using a lot of the other appliances and energy hogs in the house. And the other thing to do is, if you're not able to work at a job because of your caste, then become your own job. Prepare your own food at home, grow your own food, and think of what you can do and how you can work from home. There are tons of YouTube videos that literally teach you how to propagate plants from the foods that you buy at the grocery store. That's definitely worth experimenting with. But the important thing to understand is that this is happening. And so you've got to aggressively protect your health. Now, our health food store, which was a pretty good health food store, just closed. So what I've done, I don't have them right here, I actually baked my own organic crackers. So these are things you can do, and it's actually simpler than you think to bake your own crackers, and a fraction of the cost. So those of you who say, "Oh, I can't afford to go organic," yes, you can. It's pretty easy, especially now that you're home. You can start doing these things. The other thing I developed a taste for was fruit juice. I have no idea why. And so I went online to look at fruit juice recipes. And I realized that I could make my own fruit juice without sugar. And just the hint of fruit in there would be more than enough for me. So the thing to realize then is you can be a lot more independent. It's going to be great for your health and your pocketbook too. Now, the other thing about these death figures is people are not receiving medical care. And so it's very encouraging to see it's not necessary, that people are not dying in large numbers because of lack of medical care. In fact, they may even be dying in fewer numbers. So we'll have to see what these numbers actually show. So that would be the solution. Now we have time for a couple of questions. Let's see. You know, all I need is just a little more technology. A little more technology. Okay, question about pine trees. Thank you for your presentation last week. I found it very informative. I have friends who live in remote places. What type of pine tree is good to use if access to turpentine is not available? Actually, any pine tree will work if you can't get access to pine. So what I found was they cut a pine tree down in my backyard, and the liquid that popped out smelled just like turpentine. Smelled and tasted just like turpentine. So yeah, that's not going to be as strong as the distilled fraction, but it's going to be helpful. Okay. We had another question. Let's go over here. And so people ask, Dr. Dan, what's everyone dying of? Answer, same thing they died of last year. It's just being renamed as COVID. What about these folks in nursing homes? Again, they're dying of the same thing they died of last year. And it's simply being called COVID. And so, yes, they're still dying of bed sores. Yes, they're still dying from their medications. Yes, they're still dying from their diseases. Yes, they're still dying from malnutrition. However, it's being labeled as COVID. And death rates in nursing homes are very high. Let's see. My father has been experiencing eye boogers. I guess that's pus in his eye. In the corner of his eyes throughout the day. I have him drinking water, and he's on a non-aggravating diet, whatever that might be. Can you please tell me what could be the possible cause of this and how I can resolve it? Number one cause would be constipation. So get him to poop 3 times a day. And the next cause would be a blocked or clogged liver. You can help with that by giving him liver to eat, chicken liver or calf liver. Those would be 4 to 8 ounces a day. And I would not be too aggressive to resolve this, because his eyes are acting as a safety valve for the release of toxins. that his body has got to get rid of. So I would work more on getting the liver to work better. What foods or supplements to take for getting strong teeth? There really are no good supplements for getting strong teeth, and the best food is cow feet. Okay. All right, so a lot of people have some really involved 5-part questions. Those are better handled with an appointment, and that would be at vitalitycapsules.com and click the appointment tab. Is there anything that you can do to repair the skin and remove a biopsy scar? The skin was sliced off. So I don't know how big the skin is or what the gap is, but or what the scar is. But let's just say the scar is a divot like this in the skin. They sliced it up. For that, eating pig ears would be the best thing. Like 1 or 2 pig ears a day. Make sure you have, plenty of cooked vegetables, raw vegetables, rice, and water with that. All right, that is it. Our time is up. And we'll see you next week. As always, think happens.